Welcome to my presentation. My name is Daan van Hoff, PhD candidate at Radboud UMC in Nijmegen, the Netherlands. On behalf of my research team, I would like to thank Virology Education for granting us the opportunity to present preliminary results of our claims data study on the influence of addiction on healthcare consumption in hepatitis B and C positive patients. There are no conflict of interest. As a result of the route of transmission, HBV and HCV are prevalent among people who injected drugs. Having an addiction may cause barriers to treatment. We hypothesized that barriers such as fears and misunderstandings, stigmatization, and financial concerns would be more common in patients with a history of addiction compared to the general population. This might then result in lower healthcare utilization levels in this subgroup of HBV and HCV patients. To test our hypothesis, we queried the Dutch National Database of Healthcare Claims, CBS in Dutch. We identified all newly diagnosed HBV and HCV infected patients in the Netherlands between 2014 and 2017 and collected all HBV and HCV related healthcare activities and medication prescriptions in the patient's first year after diagnosis. Addiction history was then obtained from mental health care claims data. We grouped relevant care activities by type, for instance, visits, laboratory tests, or radiology. Next, we categorized all patients into degrees of healthcare consumption: low or loss to follow-up, medium, pre-therapeutic assessment, or high, treatment initiation. Loss to follow-up patients are patients with a maximum of 2 outpatient visits and 2 lab tests, no other interventions. Pre-therapeutic assessment category patients had either more than 2 visits or lab tests, or at least 1 abdominal radiological imaging or biopsy, but no treatment. Treatment initiation patients also used HBV or HCV medication. We are still in the process of validating these categories with the help of a panel of hepatitis treatment experts in the Netherlands. We identified 15,017 patients with an HBV or HCV diagnosis between 2013 and 2017. We included 6,680 patients with a new diagnosis. Of included patients, 60% was male. The mean age at diagnosis was 48 years old, and addiction history was present in 13.5%. Surprisingly, we found that patients with a history of addiction were less frequently lost to follow-up or in the low category compared to the non-addicted population, 11% versus 13%. Fewer patients with an addiction had medium healthcare consumption than without a history of addiction, 37 versus 41% respectively. Treatment was also more frequently initiated in patients with a history of addiction, 52 versus 45%. All differences in proportion were statistically significant. Our results show that HBV and HCV healthcare utilization among patients with a history of addiction is better compared to non-addicted patients. This could be explained by the well-organized Dutch addiction care infrastructure. Other factors may also contribute. For instance, influence of the migrant and MSM population among non-addicted patients. The preliminary analysis seemed to indicate an even distribution among groups. Comorbidity may also have an effect, as receiving care for other problems may lower the threshold to engage in HBV or HCV care as well. We are still looking into this. Important to note is that our population consists exclusively of patients that have visited the hospital at least once. So patients that were lost to follow-up before referral were not included in this study. Efforts to increase linkage to care may still be needed in this population or primary care. Thank you for your attention. Are there any questions?